anesthesia, food and AC.
Yes, yes. So you should know how to use, that's what. And if anything happens, how you should handle, that is very important.
Sir wants to add.
Sir, good evening.
Yes, sir. Good evening.
Uh, I'm a private practitioner, practice in my place. And very regularly I come across patients having tachycardia more than 140, 160 just before surgery. So after hearing to your classes, I have a confusion right now. What other modes of medications or methods we can use to reduce the heart rate, which abruptly rises just before surgery, just before anesthesia?
So
And
before
say a cesarean section.
before that,
say
few doubts, sir.
Ah.
Whether you have seen the patient before.
Before only, everything
Pre-medication,
comes now. Yeah,
pre-medication has been given.
ECG, yeah, ECG, all comes to be normal. Once they come onto the table, probably because of
Maybe
even
anxious.
with the medication, anxiety, it keeps on going in spite of my reassurances, my own experience I'm telling. Reassurances also, and suddenly they come for a emergency cesarean sections who are in labor, probably the pain also might have added to that tachycardia. And how do we
So
tackle in such situations?
first thing is we should give a good pre-anesthetic evaluation. Second thing, get good pre-medication, anxiolysis, whatever.
Anxiolysis.
Then third thing is actually if the pain is the cause, so once the pain is removed by surgery, it will actually tachycardia will settle. And if the patient is young and not got any cardiac disease, I don't think you should worry much about the tachycardia, 140. Maybe
140,
but you have to rule out one.
Up to 170 I have seen.
Yeah, but
even last 3 days back also I have
so
encountered.
you want what you
all
do,
this,
sir?
but I used to use that beta
No,
blocker.
what you use, which beta blockers?
Esmolol I used to use.
Esmolol actually very short acting.
Short
Actually,
acting, yeah.
it should not cause much problem.
Uh-huh.
But the only thing, as a lawyer, if I ask you, you have used Esmolol, do your hospital has got a pacing facility?
Yeah, that is why I am asking now.
That's what.
I saw your classes, no?
So that's why I have everything. I have this is the drug actually recommended for that scenario. But I have got pacing facility. I have got inotropes. Then you can justify like that. But if you are working in a remote place where nothing is there, then you cannot defend.
Though my place is not a remote place, but we do not have a facility to pace the patient.
But that's what they catch actually. Even one.
Yeah. If that's such in that situations, would you enlighten us like
That is where actually what you are using is a short acting.
Short acting.
You are giving a titrated doses.
Yes.
Okay, you don't require a pacing. Still, I agree with you should have a pacing. But yes, you have a control how much to give and how much you need to bring it down.
Yeah.
You have a very good control over what you are giving. So I think
99% nothing happens. 1% is the problem.
Yeah, all these days 100% nothing happened. Yeah, after hearing your classes, I just
since ages we are using Esmolol for the stress. I mean laryngoscopy and all those things we are using.
Yes, we are
so
using.
we never encounter. I think none of us experience any
I
kind of
have
this
not
one.
encountered. Yes.
Including the bradycardia. The moment it start coming down, we actually stop the infusion.
Yes, yes.
That is how we do it.
Yes.
That is what the recent guidelines and modification tells us. So only thing is you have to control the heart rate, make sure that it doesn't cause the hypotension or a bradycardia. That is what the guidelines newer one says.
Yeah, guidelines restricting is having a pacemaker facility.
Pacemaker is the added advantage, as he was rightly suggesting. Suppose if the something goes wrong and you are in the court of law, they will ask what is the backup, what you are having. I think sir is also there. He is going to add to that one. So you need to have a backup. Without backup, you cannot do it. So it is as good as if you don't have oxygen, you cannot give anesthesia.
Yeah.
It is as simple as that one. So ideally, you should have a backup.
Thank you.
Any questions?
Any questions? Any?
This question is not for the presenter. I just want the situation to be slightly cleared out. For the doctor who has asked, all patients are getting heart rate 120, 130 plus, I just want to know, are you using atropine routinely for the patient? I just wanted to make that point clear out.
What I want to add is majority of the patients, whether it is freelance practice, even in medical colleges, the aspect of pre-medication anxiolytics is generally not taken care well. People hesitate to give anxiolytics. People don't give diazepam thinking that that will delay the recovery. And alprazolam is not enough to allay the anxiety in a good way. So there is no other better drug. So that is why people don't give anxiolytics. Our PGs, if you ask what pre-medication is given, they always say just Pantop. They just give Pantop, they don't give any anxiolytics. That is one of the main reason why patients get tachycardia. What I usually do is, many a times I give one of the opioids like butorphanol. Initial days we used to give pethidine, which generally takes care of the painful condition that the patient has, and to some extent it definitely takes care of the anxiety. Some anxiolytics you have to give because all the patients, whether they are educated or not educated, they are very much anxious about the surgery. So anxiolytics definitely prevent this tachycardia. That is my opinion.
Sir, to add to that one, that drug needs to be titrated based on the weight of the patient. That also they don't read. They generally give 0.5, 1 mg like that. So,
Yeah. So anxiolytic usually previously were given. Okay, they'll be all right. They'll not have much tachycardia. If at all you take a electric case between 7 and 8. Because of the huge list, if you're taking at 11 o'clock, 12 o'clock, because of the nil orally, dehydration, electrolytes, naturally it's bound to increase. What I usually do is, if my case is not scheduled morning, if it's supposed to be at 11 o'clock, 12 o'clock, again I repeat the anxiolytic morning also. I find it very comfortable.
Any further question?
Dr. Kamath,
Srinivas sir is.
can you tell me the students, so what is the take-home message? Pros are what, cons are what?
Take-home message is actually, I have observed tachycardia 140 is also.
Sir, 1 minute. All basic things we are forgetting. The main anesthesia is plane of anesthesia. Surgical plane of anesthesia, we are not maintaining, there will be definitely hemodynamic disturbances. Either heart rate increase or blood pressure increase. Definitely it is due to the plane of anesthesia, one thing. Second thing is, everywhere there is increase in heart rate, use beta blocker is not worthwhile. Only the patient who have got sympathetic oversurge, where we expect sympathetic oversurge, there only we can use beta blocker justification. Third thing is, beta blockers are contraindicated, where else? Asthma, some other sensitivity fellows, there you should not use. If you use it, there the contraindication, overactivity, then you will be sued in the court. Pacemaker is necessary only long-term beta blockers are used. Already patient is taking beta blockers, again you are using beta blockers, then only pacemaker activity comes there.
Yes.
Otherwise it will not be a pacemaker activity is there. Definitely these are the basic things, we are forgetting things and we are discussing so many things. The beta blockers are the life-saving drugs, sometimes they save the life because tachycardia is the main culprit for MI. So you have to prevent that one. So that is the one we have to remember this one. Pre-medication, anxiolysis, all the things, we have to step by step we have to manage. If you are not giving one drug, you have to add another drug.
Yes.
That is the happening here, situations. So this is my addition to you. Thank you.
Yes. So, yes, many studies have told actually, MI it reduces, but hypertension, bradycardia, that we should know how to treat that. That's what. Sorry. The question. What was the question, chairperson?
Anyway, it is good presentation. Just tell the PG students that where we have to use that is beta blockers, where we have to not to use beta blockers. I think that is the take-home message.
And not used routinely for all the tachycardia, you should see what is the rhythm there. And for all tachycardia, if the more than 140, you should not give beta blockers. Just to obtain the intubation response, commonly use esmolol they give. But we have got other agents also. If you are not sure, other agents like fentanyl can be given, xylacod can be given, like that. So if you know how to treat, everything is there, then only use beta blocker. That's what I am treating. Don't overuse it for all cases, routinely.
Thank you.
Thank you, sir.
Thank you. Well presented.
Thank you to both speakers for a stimulating and balanced debate. We now request the chairpersons to kindly present mementos to both our speakers. We now request Dr. Ramesh Tikare sir to present the memento to Dr. Prashant Sajjan sir. We request Dr. Suhas MK sir to present the memento to Dr. Manjunath sir. We now invite Dr. Suresh YV, sir, professor from KMC Mangalore, to present the mementos to our chairpersons, Dr. Ramesh sir and Dr. Suhas sir.